Patients and what kind of providers? Is there any mention of? Uh-huh. Okay. So there's an interesting one that you mentioned, but you're not mentioning now. There's another, in the South African context, there is a person who is very, very important. No? No? No, no, no. It's what we would call an invisible actor. The security guard. Yeah? So I have a special interest in these kind of invisible actors because, for example, security guards in South Africa, there's a lot of these institutions, health centers and hospitals. Obviously, they have big security issues in many cities, but everywhere in the country, really. And there's always a security guard outside. And the security guard is usually intended to obviously protect and check who's coming in, who's going out. But they often play an unseen role in terms of triaging patients. So they will already decide who goes where, or they're already translating, you know, for somebody who doesn't speak the language, and they're supporting people to get to the right place. And I find that fascinating. I always thought I would love to do interviews with security guards. A similar interesting unseen cadre in the Indian context in hospitals is the ward boy, right? Because they actually do a huge amount of beyond sweeping or cleaning or whatever. They're doing so much interactions with the patients and mediating between patients and providers. So when you look at actors, always think beyond the conventional actors that are typically representing the health facility or the health system. And think about those people like cleaners, like porters, like, as we said, guards, etc., and what role they might have, because often they fulfill, at the micro level, a social role, a software kind of role, in terms of enabling access, but also enabling communication, which can be very interesting. Okay, so just a reminder of where we are. We are at the collecting data stage, right? So we already have some insights at the meso level. At the macro level, we've been talking about policy, policy analysis, and using document review, using key informant interviews, using stakeholder analysis to obtain information about what's happening at the level of governance and funding structures, international versus local transfer of policies. We then went to the meso level and we talked about different kinds of theories that can be used to understand how collective groups, for example, patient groups or provider groups, how we can understand the networks across them and the power of those networks, the influence of those networks. And we talked also further about looking at things like organizational culture. Now, just to go back an instant, you might say it's difficult to capture organizational culture because sometimes we ourselves are so immersed in a particular culture, because as I always said, it's not as if the culture within the facility exists independently of what's outside, right? So if you as researchers come to a clinic, you are carrying your own baggage. You're already, so there's certain things you will not even notice. The issues of certain hierarchical relationships, the way people are behaving with each other, because it's very common outside of the hospital as well, right? Whereas if we take you to a different setting, you're going to be much more conscious of those things. So just be aware that issues of organizational culture are never very far from culture with a big C outside of the health system itself. And we need to think carefully about how we document those things. Good. We've also actually moved to some extent into some ideas about analysis, because everything you're doing is already analytical thinking. Yeah, you're ranking, you're prioritizing, you're looking at relationships, you're grouping, and you are establishing mini theories about why things are the way they are. Okay, so here we are. Okay, so now we're going to move to as I said, the micro level of health systems. And I'm going to suggest that we're looking at the health systems from below. But below doesn't mean the bottom of the hierarchy. It simply means from the perspective of people's individual experience, their individual perceptions, their individual level interactions, okay? And I'm going to briefly remind you of the kind of schools of anthropology, medical anthropology, that inform how we look at human interaction, not only in health systems, but generally. And then we're going to look at a kind of thing that I've developed with colleagues, which is essentially around the relational approach to the health system. So what does it mean to take a relational approach? So when we first started, and I don't think we asked you really at the beginning what, you know, we asked you what a health system was, right? And we said, please draw us how you conceptualize the health system. And I think all of you came up with quite interesting ways to conceptualize it. But if I had an even bigger group, and if most of you were not social scientists, but you were bureaucrats or technocrats or mainly medical people, your view of the health system might be one that we could label as a view from above, yeah? Which is this bird's eye view. Very much a focus on the functions, the components of the system, a normative idea, yeah, because you would want to be able to categorize the health system in a way that allows you to go around the world and similarly look at those functions, the financing, the governance, and so on. You also might have a view of the health system that is restricted to serving the purpose of addressing health. So you might not have considered the legal system or the transport system or the education system necessarily part of the health system, or even you might not have considered the community as part of the health system. Most work, as I said to you, before 2000 on comparative health systems started with this view from above, yeah? The boundaries were fixed. Biomedicine was seen as the gold standard, yeah? So most work on health systems performance was done in high-income countries. And in those countries, even though there was an existence of multiple traditions, but basically the orientation was around allopathic or biomedicine. Yeah? So now we're going to suggest that, so this is kind of a monolithic view, right? So now we're going to move to a view from below, and you're going to say, well, we've been looking at it from below for the last 5 sessions already, so this isn't so radical a move. But we're going to do this more explicitly with respect to the micro level. So in this view, we're very much interested in practices, actors. We would acknowledge that the relationships across components of the health system are complex. Context matters. It can be chaotic in terms of how something has a knock-on effect. The systems thinking people would argue that there is a predictable way of looking at systems interactions, but it can be fairly chaotic too, because if you have a shock to the system that's unpredictable, things will get disrupted to the extent that it's not predictable, at least for a while, right? And we acknowledge in this view that the boundaries of the health system fluctuate. So even something as simple as thinking about the health worker who goes home at the end of the day and is taking care of their children, or taking care of elderly parents or in-laws, or doing some side clinic, a private clinic on the side, they're moving between boundaries, right? They are part of the health system, but they're also part of the community. And sometimes that moving back and forth is more explicit when you think about a community health worker program. They are positioned already between the two. But generally, any health worker is also a community member. Okay, we tend to forget that. In the monolithic view, it's just doctors are doctors, nurses are nurses. We kind of forget that there are lots of other things as well. And in this view from below, we also recognize that no matter where in the world you are, biomedicine or allopathic medicine is probably seen as having the highest perceived legitimacy or authority in terms of medical knowledge, but it coexists with many other medical traditions. If it didn't, we wouldn't see such a high demand, right, for different kinds of medicine. And I'm talking about rich countries as well. I'm talking about, you know, you go into any pharmacy in Germany, you're going to be able to access not just allopathic medicine, but homeopathic medicine, which apparently originated in Germany, something I didn't know. And you're also going to find a whole range of other kind of complementary remedies. Nobody really acknowledges it fully because the traditional, the formal system is an allopathic system, but there are lots of options within that allopathic system that are open to you. So even in the street where my parents used to live, you go down the street and you'll see a clinic where there is a naturopathic practitioner, 2 Chinese practitioners, Chinese medicine practitioners, a holistic well-being something or other practitioner, and then in the same building you'll have your standard GP, your Hausarzt, which means a house doctor. So that's all under the same roof. Okay, whether they get along or not, we don't know, but they're certainly sitting under the same roof. All right, so that might surprise you because you think, oh no, over there in Europe they're all oriented towards biomedicine, but in fact it's pluralistic. All right. Okay, so now we're going to look at which kinds of actors make up the health system. And these are rather old photographs, so forgive that. But when we traditionally think, if I asked you, okay, who is part of the health system? These ones are fairly standard. Not very difficult to come up with these, right? Your mother-child clinic somewhere in Uganda, where you see babies being weighed, you imagine maybe it's a community health worker, or a lay health worker, a village health worker. A consultation somewhere in India where you visibly see through, again, the symbols of the white coat, the hat, etc., the positioning, you recognize, okay, that's familiar. Those are nurses and doctors, something you don't know what kind, but you know, you roughly say these are some sort of health workers. Your surgical teams in an operating theater, it's also something that you instantly recognize across, right? When you go to this, pharmacists, would you say that they're part of the health system? But they're also part of a very highly privatized sector, right? They're also a business. Okay? But they're still part of the health system. Why? Because for many people who don't have a clear access or they don't have the time, if they've got some issue, they go straight to the pharmacist or the chemist shop. So I always found this very fascinating. This is somewhere in Bombay, that those pharmacists that are stocking all kinds of drugs, there is order in this chaos because they'll know exactly which row, which column to go to. I always found this very interesting because I thought, I mean, how on earth, right? And then this one is in Beijing, where you have an example of an apothecary, which is another name for a pharmacy, but a highly formalized one because, of course, like Ayurveda, Chinese medicine is a so-called grand tradition. It dates back many thousands of years, and therefore it's an institutional form of medicine, which means that the pharmacies have a high level of legitimacy and authority because there are schools, there's training, there are specific, there's specific research and development streams which are always testing the different kinds of preparations. But okay, so we're expanding our mind. We're saying yes, nurses, doctors, but also pharmacists, right? But then we're also looking at these types of health systems actors. Okay, so these are traditional drug sellers in Myanmar, and you can see a range of roots, herbs, some kind of, I think these are porcupine quills. You know, the animal that has those very long things. And on the right-hand side, I find that also fascinating. So it's something like the Bombay market, where you have people selling allopathic drugs, some of them expired, some of them outdated, whatever, we don't really know. And that's in Peru. Okay? Now, this is also within the boundary of the health system, whether you like it or not. Because you're going to have people who use these. So when I was recently in Uganda, it was as bad traffic as here, by the way. So in Kampala, you get stuck on the road. And people are selling all kinds of things. There's like a moving feast of things happening. Pineapple, plastic bags, toilet paper, whatever. And then I'm like, wait, what is that? What is that? And there was bags of roots. So I said, and they said, oh, and the driver next to me laughed heartily, and he said he was a bit embarrassed. And I said, no, tell me, what is it for? And he said, well, you know, men's power. So I thought, okay, I get it. So all kinds of drugs. And you see that. You see ads all over the place, you know. Lost your love, we will help you re-find it. Lost whatever. You know, marriage broken down, we will bring it back to life, etc. So not just sexual health or potency, but also the predominance, people's need to satisfy a number of health issues through non-conventional methods, right? And so these drugs were being, not drugs, but these sort of bags of roots were being sold quite openly, and people knew exactly what they were for. Okay, so those are, this is to remind you, this is a very old paper, but I still like it. Jerry Bloom and Hilary Standing, who talk about medical pluralism and the marketization of healthcare. And I think it's useful because it really helps to remind us that no matter where we are in the world, we can think about the health system as spreading across actors that operate both within the market economy as well as the non-marketized economy, and the broader categorization is organized versus non-organized. So what they've done here is they have divided it according to the function, okay, public health, skilled consultation and treatment, medical related goods, physical support of acutely and chronically ill, and management of intertemporal expenditure. So this is also different kinds of official and non-official, or rather informal, ways of protecting people from financial risks expenditures. So the money lending schemes, those kitty schemes that people have, very, very common in Uganda. Again, most of sub-Saharan Africa is that people are part of multiple WhatsApp networks, but there's also huge demand, right? So, you know, I remember my research colleague there constantly getting messages, and I was like, what's happening, Justine? Why? And she said, oh no, it's so-and-so's, there's a funeral there, so I've got to contribute. And I'm like, but how are you contributing? And she says, no, it's a matter of whatever it was, the equivalent of 10 euros, 20 euros. She says, but when it's my turn and when my family is affected, I benefit from that. So, of course, there's very interesting work around your location in the hub of those networks, because if you're a member of somebody who works with an official health system, people call on you a lot more and you become a bit overburdened and burnt out. So we also saw that during COVID, especially in countries where, I mean, I'm sure in India as well, where oxygen supplies were low, the system was overburdened. The people who had some social capital in terms of their ties were really getting a lot of demand. Anyway, we're not going to go through this table, but this is a nice one to keep at hand because it will remind you that you could do this kind of exercise of mapping actors within any country. Okay, so again, this is a nice little paper that I pulled up yesterday. This is examining roles and relationships of actors in a community health system in Nigeria. And in many African settings, like here as well, the community health system is kind of the basis for understanding how health is delivered, especially for most parts of the country that are not privy to this, you know, nice privatized services in urban settings. So it's a complex web. There are multiple players. They're producing, they're advocating, they're supporting health at household and community levels. Outside the well-known actors, there are many hidden players. So like I was saying to you before, I'm interested in those hidden actors. And they exist in the community health system, and their roles and contributions are barely acknowledged, but they're an important part of this web. So again, this is an exercise that you have started thinking about in terms of you know, your stakeholders or your different kinds of actors. And here they're trying to do this difficult exercise of connecting them. So anything unfamiliar? Philanthropists, informal providers, and so on. Okay, good. So now we're going to suggest that anthropology is a discipline that has some unique insights or contributions to the study of health systems. And when I first went into, for example, I started working in London many years ago in 2001, the anthropologists were seen as kind of clearly social scientists, and the health systems people were seen as mainly economists. Yeah? It was mainly kind of dictated by economists or health services researchers. So the two didn't really meet. And then I had this very excellent mentor called Barbara McPake, who was interested in bringing in more social science, because she said, actually, what we see in the health system, even as economists, is that so much of behavior within the health system, thinking about performance incentives, or thinking about, financing reforms, why they work or not work, so much is about human behavior. So we really need closer collaboration with social scientists. And she brought on two anthropologists, one of them being myself. And we had a program which was called the Health Systems Development Program. And that was an early program. I think it ended in 2006. But it was very productive in terms of thinking about how anthropologists could more directly contribute to the study of health systems and policies. So anthropology, what does it bring to the study of health systems? It's a uniquely humanist perspective. And by humanist, we simply mean that, it's grounded in a very sympathetic view that no matter what your behavior or whatever your practices or whatever, we're always going to try to understand it in context. We're going to try to give it meaning. Okay, so there is no such thing as condemning, irrational private provider behavior. It is rational for them. Why is it rational? So it's up to us to uncover the laws that govern people's behaviors rather than labeling it as irrational or, a belief rather than knowledge, etc. So a lot of what we're doing in anthropology is bringing humanity to people in whatever situation they're in. Our stance is always going to be a relativist paradigm or constructivist paradigm, because we're in that unique position to really explore the tension between the normative construct and practical knowledge. So by a normative construct, the normative construct could be, there are ethical guidelines. This is what we're supposed to be doing. You're supposed to be getting consent, protecting people's confidentiality as a provider. These are the normative guidelines. But we're trying to see, okay, so within their world, there's a breach of some kind of guidelines, but there's a rationale for that breach, okay? And the rationale might be, like you saw in the case of the South African clinic manager, is that they're operating under such constraints that they have to sometimes jump formal requirements and make ends meet. Or there is another cultural logic. And that logic could be as simple as I operate in a context where individual level consent has no meaning because patient autonomy is not a concept in India, or wasn't for a long time. This idea that a patient individually makes their decisions in a society where the family is so important to those decisions about health and decisions about healthcare. That individual level autonomy, taking consent from a lady who is about to have some kind of procedure, for the provider to call in family members is not a breach of guidelines. It makes sense given the cultural context. So as an anthropologist, you're always looking at what is not just cultural, what's the cultural, the economic, the practical, the social norms that are governing this situation, that give it meaning, okay? Now there's two different approaches in medical anthropology that we use to shed light on human dimensions of the health system. And I'm not going to go into depth into them because I think many of you have some training in anthropology, but also because I think that's beyond the scope of this course. But the first branch is kind of looking at health systems as a cultural system. So really focusing on the ideas that drive the practices within the system. And the second one is looking at it as a social and political institution. So that is really more about the social relations, including the power relations. Okay? So you might say, well, I'm not sure about the difference between these two yet. Okay? So I'm going to help you with that. The approach to looking at the health system as a cultural system is also known as an ethnomedical approach. And it's an approach that comes from studying health and illness in a classical kind of anthropological way, whatever, not centuries ago, but maybe 200 years ago, in non-Western settings. And for cultural anthropologists, the focus has very much been on cultural meanings, ideas, and how they shape individual behavior in illness episodes. They're not so much interested in provider behavior, but their focus is on really understanding people's engagement with the health system. What influences whether you seek care or not, how you respond to advice or recommendations given, and so on. The emphasis is very much on patients, or on communities. And in fact, there's still a lot of anthropology that is taught which focuses on that level. Okay, they're not really interested in the culture of doctors. They're interested in the culture of people who are engaging with medical ideas, medical practices, medical systems. So there is something where culture is being reified at the expense of structural context. And reified means it's been given a status of its own. It's like this cloud which hangs over us, okay? As if everything that we do, our ideas, our ways of going about things, is culture. Okay, so there's not much attention on my structural status, my social status, my economic status. It is mainly focusing on culture. And I have to say that there is still a lot of anthropology that is driven by this idea of culture and its impact on ideas. The other approach stems from the opposite. It stems from the study of Western medicine. So for a very long time, in the pre-World War II period, the classical anthropologist in the West, in northern countries, was somebody who either was an armchair anthropologist, who didn't have the capacity to go and travel abroad, but they relied on accounts that were being brought back by missionaries or colonial administrators, and they would collect, as if they were collecting butterflies, they would collect beliefs and practices, and then they would write up these great big tomes about, the XYZ tribe in this country, the Balinese of Indonesia. And so they were really doing these comprehensive things. Then you get this move towards fieldwork, where you get lots of anthropologists going out, spending a lot of time in the field. But then what happens in the 60s? What's happening to a range of countries that were formerly colonies? They're becoming independent. India, of course, 1947, but African countries around the 60s, right? So nobody wants anthropologists hanging around anymore. In fact, they're seen as closely linked to the colonial enterprise. So what happens to the anthropologists who before were happily swanning around in, some place? I mean, it wasn't all easy, but they had the luxury of going out and spending long periods of time on some islands in the South Pacific, or I don't know, I'm sure in India there were also particular areas which had anthropologists which are famous. I know that as famous sociologists did a lot of work on caste in India based on field work. But what happened in the 60s is they were chucked out with the rest of the white folk that were still hanging around. So the gaze turned inward, and the anthropologists start to say, okay, let's look at our own institutions. So our hospitals, our healthcare delivery, and the 60s and the 70s is a very, very important period in North America, particularly. In the United Kingdom, less. There's not really much of a tradition of medical anthropology in the United Kingdom until later, I think. But basically, you have, feminist movement taking off, civil rights movement, and later, of course, gay rights movement. And what that also led to is it's essentially a very fertile period for critical views, including critique of the biomedical system. So the anthropologists who are looking at their own systems in the US are starting to recognize how the medical system is gendered, how it is iatrogenic. In other words, it's producing sickness itself, right? How there are power struggles within the system. So the hierarchies within the system and how they lead to suboptimal delivery of care. And they're looking at things like mental health and how it's being handled. Because for a long time, mental health was medicalized heavily. And the interventions were geared towards, essentially, were quite invasive and quite barbaric almost. So all of that's happening in the 70s, and you have a branch of medical anthropology which is closely aligned with political economy. So it's known as a more political stance, critical medical anthropology. And it's coming from the study of systems in rich countries, essentially. Very much a focus on social relations, access to power and knowledge at different levels of the system. And the emphasis here, interestingly enough, is not so much on patients, but it's on providers. Because patients are seen as victims of the system. And so they're really looking at power relations and how they shape authoritative knowledge in medicine and how they shape relationships in the system. What is interesting is that here it's more a focus on beliefs, practices, knowledge, ideas, but nobody's looking at the structural context. Here there's so much emphasis on the structural context that they're kind of giving less emphasis to subjective experience of suffering. Okay? So these are the challenges with the both, with the two polar kind of opposites. Now, of course, I've given you a very dumbed down version of these two branches, and they're obviously much more sophisticated and they have evolved considerably since. But I think certainly when I was studying anthropology we were very aware of these two branches, and we knew that a lot of applied anthropology, as it was applied in, for example, public health, was predominantly this kind of anthropology and not the other. Okay, the underlying premises of the medical system weren't necessarily questioned. You might say, okay, they were very critical, but essentially biomedicine, it was, the basic problem for the political economists working on health systems was not that biomedicine in and of itself was flawed, but that it was inequitably distributed. So the limitations of both of these approaches is that the patients or individuals are kind of pawns of the system, yeah? In one view, they're kind of dictated by culture, yeah? Which is why there's so much emphasis also in Indian anthropology for many years on cultural beliefs, as if people operated, with this cultural cloud hanging over their heads. Beliefs and practices. And we didn't really look at their agency, their ability to bypass, to overcome, to resist, to contest, and so on. Okay? There was just this idea that people behaved in certain ways because they were dictated by their culture. The sources of power and knowledge are kind of assumed and seen as static. So often both of these views don't capture the fact that things change. Culture changes, but also the political context changes, people's status change, and so on. And there was a lack of interest generally in how global health imperatives were translated in local contexts. So those working on kind of health systems as cultural systems tended to focus on specific cultures. So there would be, the health of X tribal group in India, yeah? But nobody was putting them in relation to the rest of what was going on in the country. It's very focused on small-scale studies. There was also very little emphasis on actual practice. So what I'm going to propose is that with colleagues, we have kind of been drawing on ideas from both branches of medical anthropology, but also trying to develop our own way of looking at the health system that gives credit to the fact that people have agency in the system. Whether you're a provider or whether you're a patient, you have ways and means to navigate the space of the health system. Sometimes it's very constrained by your social position, but we still need to look at you as a dynamic actor that's operating within a structure. So if we think about a relational view, we're essentially moving away from the organogram. This is also a way of depicting a relational view because people in this organogram have a relationship to each other. It's a hierarchical relationship in the classical kind of organogram of a hierarchical organization. And we're looking more at this kind of relationship. So we recognize that formally this is going on, but we think that many actions within the health system are more dictated by relationships, so relational power. So we think that those relationships exist within the infrastructure. So what does this mean? We're going to look at a few different aspects. The first is that the material infrastructure and technology of care is deeply intertwined with social and power relations. So you could see that a little bit in the transcript that you looked at. But essentially, we're trying to understand the ways in which, in a health clinic, for example, the manager's ability to, let's say, fulfill her tasks in a satisfactory way is highly dependent on the space, the infrastructure, the resources, and the chain of command. They're all intertwined, yeah? This is a very high-tech new surgical unit. Where do you think it is? Any idea? You're probably checking out the people and trying to get a clue. It's in Rwanda. Rwanda is a country in East Central Africa, which has a very, very advanced health system. Surprisingly advanced in relation to where you think it would be coming from. But they have been working for many, many years with something called Partners in Health. In the US, I'm not really sure now what is happening with the new situation. But they have just instated these very, very high-tech surgical units. And I thought it was very interesting because my first thought was, is the system ready for this? Is there going to be a mismatch between implementing something that looks top of the, really, really top of the, top of the scale, technological systems, how is it going to match with existing workplace structures, routines, and so on? But essentially, that is one aspect of relational, is that you say that you're always looking at the relationship between the technical or the technology, the equipment, the infrastructure, and the social and power relations. The second aspect is, there's a title missing here, is really around understanding the epistemology of knowledge. So this is a nice quote from a book called On Asian Medical Knowledge, written many, many years ago. And it's essentially asking this question: how do patients and practitioners know what they know? What are their rules of evidence? What kinds and categories of information do they find persuasive, and under what circumstances? How do they know when a judgment is wrong or correct? And what does wrong or correct mean to patients, to a village practitioner, and to experts trained in the great tradition? Now, I find this very, very interesting because, again, it's coming back to the fact that you always have to situate what knowledge becomes important for you in what situation. So it's a kind of a realist approach to sources of knowledge and sources of authoritative knowledge. So it is relational because it is looking at the importance and the meaning of knowledge in a given context. Another way of looking at this, which is related, is thinking about health systems as knowledge economies. So they are dynamic because they offer ways of organizing access to expert knowledge or expertise that is embodied in both people and products. Yeah, the expertise that you see reflected in the new surgical unit in Rwanda is very visible because you've got this high-tech equipment. The expertise might be embodied in people who can speak knowledgeably about something, right? But of course, this is closely related to different types of power that we talked about. So I'm going to give you an example. This is an image from a pharmacy. And basically what happens, the interactions that happen in this pharmacy, there are two types of knowledge happening. What we would call explicit expertise or knowledge. So we might look at the two pharmacists behind the counter. We might analyze their expertise or their knowledge in terms of the tasks that a pharmacist and a pharmacy assistant has. But then there's something else going on, which is called tacit knowledge, which is the extent to which this elderly gentleman who comes in and who asks for something he doesn't have a prescription, we're going to analyze that situation a bit later, is provided with whatever drug he wants and information, but this is based not so much in their technical expertise, but in their social expertise. Okay, and it has, in this picture, probably a lot to do with caste, familiarity, assessment, and an assessment of where this person is coming from. In fact, we're doing a study in Belgium now to understand pharmacists' tacit knowledge in terms of their behavior with patients of a migrant background. Okay, so this is a very interesting paper, which I think what is happening is that when I move the slides from colored slides to white slides, it's missed out some of the text, but I will make sure that you get the reference. So here the use of tacit knowledge can be applied to the pharmacist who makes an ethical decision about whether to dispense a prescription-only medicine without a prescription in an emergency or the reporting of suspected misuse of drugs by a client or colleague. The knowledge involved in making these complex decisions cannot always be verbalized, and it's based on experience rather than formal theory. Okay, so again, a relational aspect of the health system, which suggests that the way in which people assert their authority or their expertise is not always by virtue of having a certificate on the wall. It is something that is gained through experience. Okay, another aspect of thinking about this relational kind of contributions of anthropology to the health system is that when we conduct conventional research, especially when you think of positivist-driven survey research, we think of measuring things as a one-off, unless we're doing a longitudinal or before-after study. But usually we don't think about the fact that people have a long-term engagement over the course of their, say, women over the course of their reproductive lives, or for people in general. You have some kind of ongoing engagement with the health system. So it's not a one-off event. And that also is a relational approach, because it's saying that when we go out and try to understand people's illness behaviors or their interface with the health system, we need to think about it in relation to their previous experiences. Why do mothers not take their kids to be immunized? Because their last experiences of the health system were so poor that they have no trust. Yeah? We don't, unfortunately, most of our research doesn't consider that. We tend to think of the here and now. Yeah? Okay, I'm going to give you a nice example from a paper by Marion Loveday, which is looking at a patient pathway. Okay? And this is essentially a paper which is following one single patient. The whole paper is only about one patient. But it is a paper which looks at what happened, why the pathway to care was compromised. So this person has drug-resistant TB, and the legend, they basically tracked what happened over the course of, I think, probably almost a year. But essentially, it's 10 out of 24 months. They were given full and correct treatment. 4 out of 24 months, no treatment, and 10 out of 24. So if you look at it from a point of view of patient adherence to treatment for drug-resistant TB, it doesn't look great. When you analyze it as not a one-stop thing, but you look at the course of what happened, you can see months the patient received no treatment, months they received incomplete treatment, months they received full treatment. Health systems factors and patient factors. And then we look at what actually happened. So at one point the laboratory website was down, so the information wasn't communicated accurately. There was a public sector strike. There was a stock out of a major drug. Heavy rains, which led to the person not being able to access the facility. The medical records were lost for the person. No transport money, there was a missed visit, and there was another stock out of another drug. So in balance, it's a mix. It's a complex mix, but essentially one that very clearly illustrates the relationship again between patient delays, systems delays that are a result of a number of factors that are beyond this person's control. So this is a really excellent paper, and I believe that something similar was done in India with our colleague, with Sheila Rangan, which is, it's a paper called Such a Long Journey. And I think they modeled it, in fact, on this paper. I'm not sure. Maybe it came before it. I'm not sure, but it was similar. And this is also to illustrate to you that sometimes taking the time to understand one trajectory can reveal quite a lot. All right? So the relational aspect here is the issue of the temporal aspect, that when you think about engagement with the health system, the classical way is you just measure one-off visits, but think about it as a long-term, especially for people who are on a long-term treatment. So this brings us into the kind of broader notion of temporal and spatial dimensions of health systems encounters. And I've mentioned this before, my example for thinking about the ways in which space and time matter for health systems strategies. This is HIV testing and the move from, as you remember, provider-initiated testing and counseling through voluntary testing and counseling through to self-testing. And what we argued in an editorial some years ago is that we said the tests are becoming much more rapid, they're becoming routinized. But what is happening also is that we're changing the time and space dimensions because they're taking place outside of the clinic. So we're going more and more into intimate spaces, right? The testing used to take place in a clinic, then it moved into mobile testing camps or whatever, and then it moved into homes. So that transition is important to think about, what it means for the person who's doing the test. So there's a continuum of social spaces spanning the intimacy of homes and the relative anonymity of mobile testing facilities. What's also happening is that the time is changing. So in the beginning, years ago, when you had an HIV test, you had to wait 3 days for the result, right? Then we moved into a testing and counseling situation where you would get the result within a shorter amount of time, but there was a kind of delay in terms of the diagnosis being fed, the post-test counseling, and so on. And now we're moving to a situation where you essentially have it within minutes, like a pregnancy test, essentially. So our argument on the basis of work that was done in Kenya and Malawi was that rapid testing technologies may paradoxically deprive individuals of the time required they need to digest the test, the result, and its consequences, and to think about when and with whom to share test results. Okay, so this is just a very concrete example of why, again, thinking about the relational aspects, why time and space matter in health systems, and there's many other examples. Okay, the last one is, this is a very sort of simple idea, but it's often ignored in health systems thinking, is that, but you saw that in the paper that we just looked at, the South African paper, is that you have what's called, so again, my mentor, Barbara McPake, she referred to this as the dynamic responses model. So on the one hand, you have the de jure system, okay? This is the system that's laid down in protocols, in guidelines, codes of conduct. organizational structures, the incentives, the procedures. These are the things that are implemented in the system. Then you have the de facto system. The system is experienced by people. They receive better or worse, they're able less or more to access the system. They receive better or worse quality of services. And there's something in between, she says, is the dynamic responses. So it's how users and providers react and interact in response to the formal structures. And this, the argument is that very often it's negotiated through informal processes. So the de jure system, the one that is officially in place, legislated, mandated, according to regulations, is the only place where we can intervene, technically, if we're health systems people. But there is no direct link to the de facto, which is how people experience the system. So everything is mediated through health systems actors. And operating at the micro level, we are interested in adaptive responses, yeah? Especially in situations where we know that it is close to impossible to implement the guideline or the initiative as it was intended because of the circumstances. So, for example, in the de jure system, you might have a situation where user fees are removed, and it means that you're getting greater numbers of people coming to use the system, but the providers, because of their own constraints, might react by charging on the side. There might be some informal payments going on. And the users might then react by sourcing cheaper drugs from informal sources. And so all of these interactions are really about how both sides of the provider side and the community side or the patient side are adapting. And I think in her case is Barbara McPake did a lot of analysis to see why, even with all the initiatives that have been put in place to improve access of the poor to the system, that in fact the poor don't benefit because there is something else going on whereby people who are slightly better off are able to co-opt the system. Okay. So we've talked a lot about practice, so how people, what's going on within the system in terms of what they know, so that's the epistemology, what they're doing, praxis, and now we're looking at social relations. So this is the social embeddedness. And this has to do with what we refer to as relational power, or sometimes they refer to as social capital as well. And there's a nice paper on, again, individual patients' capital in terms of navigating their way into the system. And this author argues that some people are just better at finding the right person to ask where to go, presenting their sickness within the right time frame, and at presenting themselves respectfully. And I'll never forget, I had an example from my own fieldwork here in Maharashtra. I was working in Bobkil, which is somewhere outside here. And we were working with women and trying to understand, issues about their reproductive health, how they expressed it, whether they sought care. And we worked through a local, I think there was a local women's Mahila, like a temple-based organization, not organization, just a social association. And there was this very, very strong, very articulate woman who was somebody who helped us in terms of gatekeeping to the community. And this lady had some problem. She had a gastrointestinal issue which wasn't going away. So I agreed to take her to Sassoon Hospital. And in the course of that trip, I saw her status as a strong community leader, outspoken, defiant, always very well presented, crumble. Why? Because she was moving out of her comfort zone. And as soon as we reached the hospital, she was treated so poorly because she was recognized as somebody, had the traditional way of wearing her sari. She spoke a certain type of Marathi, which what the receptionist, and I saw progressively how she completely lost her status and her capital. So her capital that made her a prominent person in the community effectively was diminished in the health system because she didn't have the ways to present herself as a good patient. Okay, she couldn't articulate exactly what was happening in terms of presenting symptoms. She didn't have the ability to articulate even things about her personal background because she didn't really go to the hospital that often. And at that time I was absolutely shocked to see that, because it made me realize that it is not so much the conditions and the severity of the conditions that determine your care. It's also little things like this. It is how you present yourself, okay? And it's what's called the good, what is the good patient versus the bad patient? And the good patient is often somebody who goes and knows exactly, there's a shared language, okay? Yes, doctor. Okay. And the other patient is somebody who is articulating their complaints, but not in the same language. Language being in apostrophes, okay? But this stuck in my head for years, because it was such a powerful symbol of how the health system can disempower people just by virtue of a small thing like that. So that's kind of that. That's this issue of how the good patient and the bad, not bad patient, but the inarticulate patient is can lead to different access to care. And then, of course, we're looking at power as it's expressed through many kinds of social relations at multiple levels of the system. And we've talked about this a lot. Social interactions, the people involved, the structures within which social processes that they all influence power dynamics. And there's some excellent work on this. So let's look at another typical example of a scenario where power is very visible, right? This is the ward round, yeah? And you will instantly recognize who is who. By virtue of what? What are the symbols that immediately give you clues as to who holds authority here? Yeah, the coats, maybe the positioning, maybe she's probably the most senior, right? This one. So, which is quite refreshing, but the way, the distance, who's allowed to go closer to the bed, who's further away, the demeanor, yeah, who's allowed to ask questions. So there's papers, imagine there's papers unpacking the ritual of the ward round, because it is such a highly symbolic aspect of medical training. And they talk about it being a ritual of hospital life, which brings some sort of stability. However, ward rounds may actually simultaneously reconfirm existing hierarchies in the workplace, inadvertently reaffirming submissive social roles, for example, of nurses and patients, and hierarchical control. So different kinds of information are distributed between members of the team and the patients during the ward round, but this in fact determines the type of contribution that is deemed valid or not. And my son, who's now second year medical school, is constantly giving me examples of this. Whenever they do some kind of work in a health setting or shadowing a GP, there's so many aspects of this in terms of how, when are they allowed to ask something, how are they allowed to ask it, who gets to ask, who is listened to, who has direct eye contact, all these little things, right? So the ward round is a very fascinating ritual. Okay, let's stop there. Are there any questions on this section before we move forward? How much of this is familiar to you? It's probably quite familiar, right? For those of you who trained in medical anthropology or anthropology. Should we just check it? Okay. Okay. All right, we're going to start up again. So what we saw in the last session was essentially the move. What I told you about was where anthropology came into health policy and systems research. There was no deliberate marriage there. It was simply that anthropologists who had been working on medical systems or health systems from different perspectives, they started to work more in public health or schools of public health, and then there was a potential recognized that actually social scientists, the concepts of studying interactions at the micro level could be very helpful in understanding health systems software, which was, as you remember, a concept that was introduced in health systems thinking and frameworks around 2010, 2012. So we also said that there were two branches of medical anthropology, one that was very focused on medical systems as cultural systems, and the other one focused on medical systems as political and economic systems. And they had very different implications for understanding people's behavior within the system. Yeah? With the one, culturalist approach has tended to focus more on patients or people who are afflicted by a certain condition, versus the political economy branch, which focuses more on power relations within biomedicine and how it affects provider behavior. Okay? Then I suggested that regardless of what camp you sit in, it's useful to think about relational aspects of health systems and the fact that we need to take into account what do certain types of knowledge mean to certain people, and to not just accept that this is the be-all and end-all. This is authoritative knowledge. So even thinking about a policy or a new piece of scientific evidence that comes in, it's going to mean different things to different people. The second thing we said is to focus on practice. What is it that people do in the system? How do they navigate the system? How do providers navigate the constraints of their working environments? And the third thing we said is that we want to focus on things so that navigation includes considerations of time and space. And then the third thing we said is we focus on social relations. And there's ways of recognizing the embeddedness of power and social relations in every interaction. Okay, good. So now you might be saying, okay, this is all very nice, thank you very much, but how do we actually go about doing this? What kinds of approaches can we use? And so I'm going to be speaking to you about the use of ethnographic approaches. And you may be more familiar with qualitative approaches, and you may say, well, what's the difference? Is that the same? If I do a couple of interviews, am I doing ethnography? What do you think? No. Why do you think no?
Maybe it relates more to finding out about the context of the person rather than just that one going off a short interaction. We want to know about the context and in which the person is situated and how it influences their behavior. So we even look at their behavior and small habits to like draw a picture about.
Okay, very good. So you have an idea about context. Why is it difficult to get context from an interview, a one-off interview? Okay, let's say you're interviewing mothers about child feeding practices. Okay, you're a nutritionist, but you're actually interested in what influences, does gender play a role in how mothers decide, how to feed their children, or when and what to feed them? What happens in an interview? Yeah, you might get something about context depending on how well you conduct the interview, but in fact, ascertaining the contextual influences on feeding practices, you're probably better off if you have a chance to spend some time in households and actually observe what's going on. Yeah? So when the people are sitting around eating, do they notice, you start to notice, oh, the boy child is getting a lot more on their plate, or they're getting some preferential treatment in terms of whatever it is, sweet things or whatever, okay? So that's just a little tiny example, but context is very important. So what do we mean by ethnography? We generally mean a methodology, a methodological approach, which encompasses a way of thinking, a paradigm, and an approach to fieldwork. But it is also simultaneously known as the written product. So you can say, I'm conducting an ethnography, but the product of the work that I did over the last 4 years resulted in an ethnography. So ethnography is also the product. Yeah? Study and systematic recording of human cultures also. It is also a descriptive work that's produced from this research. So what's important is to note here that when we talk about ethnography, we're talking about methodology. And methodology does not equal methods. Yeah? So this is why we went kind of systematically through those 8 steps. And we said that methodology is part of the research paradigm. It is, you know, the aspect of how you're going to source and gather the knowledge that you are trying to ascertain about a topic. So methodology is sometimes a research paradigm, but it's part of the research paradigm. It's informed by the epistemology and the theory. And often there's a confusion of ethnographic and qualitative when you describe methods. And many times I see papers that say, we used ethnographic methods to do some observations. And a colleague of mine a long time ago, Wenzel Geisler, he said, mixing up ethnography with specific methods is like reducing cardiology to using a stethoscope. Okay, so it's not the tool, it is the whole mindset and the whole approach. So one of the most important things that characterizes ethnography is that you spend a certain amount of time in a field setting. And in the olden days, I told you about pre-1960s, when anthropologists had the luxury of spending some year or years somewhere in a remote village or rural setting or wherever. Fieldwork was an extensive period of time where they really got to learn the language, they immersed themselves, they were able to take part in daily life of the people that they were working with or studying. But it was a kind of pretty much a top-down. It was the researcher observing and kind of reproducing an ethnography about these people. Nowadays, we still do field work, but it is generally much shorter because of time constraints, but also because it is ethically and practically no longer feasible. So sometimes, what do we mean by the field? Sometimes we mean a geographic place, yeah? Which means I am doing my field work in, you know, some small part of southern Karnataka, okay? It's located geographically. Sometimes it's an institution or an organization. So the field could be, and I think, for example, many of your topics are making reference to national level or even international level guidelines. Your place of fieldwork could be the WHO, could be the field, okay? In other words, your universe of interest is an institutional site rather than a geographic site. What does that mean with respect to geography and accessibility? Let's say I'm focusing on WHO and the influence of WHO on Indian PPM. If my field work, if I want to spend some field, if I want to consider the WHO my field, what does it potentially mean for where I'm situated? Am I going to be stuck in Geneva, all of my field work? No. So where else could I be? Could be in the regional office, right? The South, whatever it's called, CRO, Regional WHO office in Delhi. You could spend some time online. So your field site becomes a movable site, right? It could be a physical structure, okay? So if you say, I'm really interested in the role of religious institutions in supporting mental health, okay? And I want to conduct research on churches. And my field site, because I have 6 months' time, I am going to, and I myself am going to do some participant observation. Without being disingenuous, I'm somebody who's going to attend and be part of this congregation of the church because I want to experience firsthand what this church has come to mean for the people of the community in terms of different kinds of support and care, different types of mental solace, refuge, etc. Okay? So the church, now you might say, that's kind of an institution and it's a physical structure. But for the purposes of this example, let's just assume that in our case we're thinking about the physical structure. I'm going to go and spend time in the church. It could also be a social space, right? So you could be an ethnographer. I did some interesting work in China on stroke rehabilitation. And even though most of our research was closely governed or dictated by what the Chinese colleagues wanted me to do, which was to focus on different kinds of hospitals and hospital care, as I was walking every day, because there it is possible still to walk, as in it's possible to walk to, from the hotel to the institution. It's easier. There's a sort of pathways that take you along a river in a very, very busy city. So there's a lot of emphasis on creating pathways and walkways and spaces. I noticed something phenomenal, which was that there were lots of parks, and the parks were full of elderly people. And what were they doing? Like you would find here, 5 a.m., you go to a park, you're going to find people walking. But there, they were doing Tai Chi, they were singing opera, they were painting with water calligraphy on the ground, they were doing aerobics classes. It was unbelievable, the level of activity, physical activity for the elderly. So I thought, I would love to shift this whole ethnography from these quite rigid bureaucratic units to understanding the whole mentality and the culture around physical activity among what presumably is a quite well-off elderly. Yeah? But the social space there would become these parks. It's another field site. And you can imagine a project designed around that, which looks at the park as a thing. The other thing is a community. And that community is also, as Solomon pointed out, what constitutes a community differs. You can also tie the community to a geographic space, but a community could be an online community. So imagine you're interested in understanding the relevance of social media groups to support people who have long COVID. So your community is not a physical one that you're going to be able to interact with in physical terms, but it's an online community. Okay, so we were planning some work which unfortunately didn't get funded, which was to work with patient networks from the French side and the Dutch side of Belgium, and our mode of entry was going to be through social media. So that was a community. They defined themselves as the Long COVID Patients Association because they felt very wronged by the government that didn't take them seriously. A culture or a subculture can also be a field, all right? So sometimes you say there's certain types of cultures that emerge around sports. Yeah, so in California, surfer culture is a big thing. It's all the people that do, kind of surfing, board surfing. Skater culture. I'm just thinking sports now. But there's other kinds of cultures. There's cultures around specific activities, leisure activities. But there's also things that are subcultures that might be associated with an identity, a social identity that is tied to, a marginal identity, a sexual minority, or a an ethnic minority, or something that is defined simply by virtue of a common shared interest that becomes so developed in terms of practices and how you think about things that it becomes a culture. Okay, so in terms of health and medicine, I've already given you a clue. I've said that WHO could be your field site. What do you think counts as being in the field? So if you're going to do a health systems and policy piece of work, what could be the field for you? Now, reflecting on your topics, do you have to go inside the health system, or what else might be possible field sites for you? Any thoughts?
Okay, both organization and this community.
Say it again?
We can take organization
Mm-hmm.
and community.
Yeah.
And we take them as
Yeah, yeah. You could have the organization, an organizational level of the field. You could have a specific community. But let's dig a bit deeper. What do you mean here by community? What are relevant communities? You don't have to use your examples, but Sakshi, Gayatri?
Relevant to our topic, we are looking into road traffic accidents. So a community for me, an important part of the research could be bystander community. So how their responses affect care. So that's an important part. Or even the caregiver community of the patient side. So that's also a community for me that becomes a field of research.
Okay. Okay. I think you have to be careful that you as a researcher don't define the community. Yeah? If the bystanders have nothing to do with each other, they don't form a community. Okay? So always take account of that. If, for example, there's a group of people who feel that they were unjustly treated by the hospital and they form an association because they want to mutually support each other, that is a potential community. Yeah? But be wary of labeling things a community when there is no self-identified thing, okay? So other things that could be fields, okay? Do you think, for example, a laboratory could be a field site for health systems work? Why do you think a laboratory could be? Or those of you who think yes, it could be?
it depends on whether it's sentinel or it's a peripheral. We can take it as a field where they collect the samples and all.
Is that true? Does the laboratory have to be peripheral in order to be a field site? Or could I look at a central laboratory? What would be my interest? Okay, putting your social science hats on now. Why might my laboratory become a field site? Yeah?
It's the whole system and the people involved in it.
Yeah, absolutely. Okay, it's a system in and of itself. A laboratory system, a pharmaceutical system, the outpatient, the waiting, I said the waiting room is a system by itself. They're all governed by certain rules, right? And sometimes those rules are implemented in ways that follow a particular schema, an algorithm, and sometimes they're not. So there is a very famous ethnography called the social, I forgot what it's called, I think it's called Laboratory Life, the social construction of laboratory facts. And it basically studies very famous labs like the Pasteur lab, Pasteur Institute, and it looks at the social dynamics of how people negotiate contested meanings of evidence that's produced in a lab. But there's also interesting studies about the transfer of knowledge from the slide to conveying it to people and what happens in contexts of uncertainty. So the laboratory and the system of laboratory, the social relations within the laboratory, the evidence, the temporal, the spatial, all those aspects, the relationships between senior versus junior lab technicians becomes a subject in and of itself, whereby the laboratory is your field site. So next time you pass the little lab here, don't forget to peer in and say, I don't think they'll be so happy, but maybe you could do some study there. Okay? Okay, other things, not just laboratories, but as I said, pharmacies have a subsystem, and other parts of the structure of the health system, but community health worker programs, obviously we've talked about different kinds of health worker programs, different types of associations, those all could be field sites. So let's talk about field work. Generally, we all think of ourselves as doing field work, even if you do a survey. But classically speaking, there's a difference between data collection and field work. So often data collection involves a short. It's a one-off presence. You pile in, there's a team of 5 of you, you do your survey, it's over in 2 weeks. Yeah? Whereas in field work, it implies a longer continuous presence in the field. In short-term data collection, the information is usually collected through formal methods. Yeah? So in other words, you have protocols, you've got your survey tool, you have your topic guides, you have a plan. Yeah? In field work, yes, you're going to use formal methods, but a lot of what you collect is through informal conversations and through observations. Because you're spending a lot of time there, you're going to get a lot of information about the context simply by noting what's happening around you. In the data collection, usually the reality is pre-existing, so the researcher is detached from the subject in the field. Okay? They don't have to be a positivist, but in general, they're not immersing themselves in the field. They're not becoming one of the field when they enter it. You're not going to enter the lab and become a lab technician. You're not immersing yourself like that. Okay? In field work, the reality that you describe is acknowledged to be a product of your engagement and your positioning within the field. So it's very different if a lab technician writes that ethnography based on 6 months spent in XYZ lab observing things versus somebody who goes in for a couple of weeks, conducts some interviews, does a survey, and is essentially assessing the quality of the laboratory systems. It's a very different story. You could still use interviews, but the idea is that you've got a set of pre-existing data collection instruments, and you're going to capture specific aspects of that reality. Whereas the lab technician who goes there, spends 6 months, gets friendly with or not friendly with the team, but is really immersed in this. They're really doing something called participant observation. They're going to get quite a different picture of, and maybe their focus is also quite different. They're not really interested in quality of the lab. They're interested in how dynamics of the lab setting allow certain types of information to flow in certain ways. In data collection, usually the fixed accounts are, the analysis is fixed and the account is reproducible. Okay, so generally, especially for positivist research, if you have existing tools, then one person from each of the tables should be able to do the same research. Yeah? Versus field work, it's a narrative analysis. It depends so much on you and your positioning in the field that it's not reproducible. So we said that in classical anthropology, often people went and they spent a long time, and now that's no longer so much the case. Today, it involves less time and higher costs. If I want to hire somebody who's capable of doing really good field work, as opposed to conducting a survey, it costs a lot more money because you're going to ask them to get out of their home space. They're going to move. They're going to stay in the community, and they're going to kind of immerse themselves for a while. But it is often short term. Yeah, it's short term, so it's more intensive. There has been development of rapid methods, rapid anthropological methods. They were very popular in the 70s and 80s. And the idea was to say that, look, if you can't immerse yourself totally, like I was saying to you, clinic observations or clinic ethnography, even if I can't spend a week or a month or half a year in a clinic to understand it fully, even doing 2 days in the clinic is going to give me more than just interviewing a clinic manager. Okay? So that excerpt you read clearly comes from somebody who's spent time observing the dynamics of that clinic. That information wouldn't be had from a simple interview, right? Today, instead of trying to represent society in its totality, which is what the old style anthropologists did, fieldwork today is responding to a specific focus or a specific question. Often there's more than one researcher, and they might be trained in less structured or more structured methods. And often the fieldwork that you're doing today, the data collection that's involved in the fieldwork context, has practical ends. So very often the fieldwork that we're conducting is in the interests of, especially if you're an HPSR researcher, you're usually trying to improve some aspect of the system, or you're aware that there's some problem. You're not just documenting it, right? But fundamentally, the idea of fieldwork is still acknowledging that it's a social exchange, yeah? And as soon as you enter the field and you spend some time there, you are having some kind of relationship or interactions. And so much of what you can do or what you're able to get as data is contingent on the relationship that you have. So one of the most important things that we need to think about when you start to do field work is your social interaction and your self-presentation. And that's critical to the success of your research project. The scope and the quality of the data you collect is really influenced by these relationships that you develop with people in the field. So you might say, oh, do you mean instrumental relationships? Do you mean like finding a gatekeeper who's going to help me access this place? It's not just the instrumental, it's the rapport you build each and every time you are interacting with somebody you want to gain some information from. It's the level of trust you build in the community that you're talking about, even with an online. You can imagine how wary they might be if you engage with an online group and you say, well, I don't actually have hemophilia or I don't actually have long COVID, but I'm interested in how people cope with it. Initially, the response might be back off, you know. You're not really part of this community. But if you explain why you're doing this research and that it's intended to support people in their position, maybe you'll be better off. Your position as a researcher, age, sex, ethnic group, caste, whatever, socioeconomic status, in relation to the position of the research participant, always be aware of that. So, you know, I think anybody with good social science training will know that when you approach the field, especially a field site that you're going to spend longer, you've got to adjust, you know, what you're wearing, how you behave, whether you march in and say, I'm Dr. So-and-so, versus saying, I'm a researcher, yeah? Even that small thing. Now, sometimes saying that I'm Dr. So-and-so is useful, because if I'm interviewing private providers and I go in saying, you know, I'm Little Miss Junior Researcher from X, the initial credibility is going to be difficult, so you have to say I'm Dr. So-and-so, even though it might make you feel very, even, you know, sometimes you don't like to play the hierarchy card. But just to get in, sometimes it's required, and then you can explain that you're not there in your capacity as the doctor or the, you know, head of department or whatever it is. But on the whole, I think it's better to be humble and to be honest and try to establish the rapport, not by means of your status, but by means of your manner, yeah, your demeanor. You're seeking a common point. So wider power structures in society obviously mean that some people's views are more accepted and more frequently represented than others. And sometimes you can't get around that, no matter how nice you are or how forthcoming you are. In fact, the nicer you are in some places, the lower down you are on the scale, because people just think this is a pushover. So if you walk in a very arrogant manner and sort of say, I'm here to collect information on blah, 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 somehow you're more respected than if you come in and you offer them sweets, right? So, okay. So that's at a surface level. But at a deeper level, when you are actually immersing yourself in the field for a longer period of time, and sometimes when you get funding, it means you're going to have recurrent interactions. What is very important is speaking the language. And a lot of anthropologists or people who are conducting ethnography now no longer speak the language of where they go, which is a real shame, because I say even if you can manage greetings, basic things in the local language, it can make such a difference. People can see that you're trying. Yeah, this morning I tried out some Marathi with the driver and he was absolutely thrilled. I could see the complete change in the shift. So I thought, okay, the next one I'm taking his life history, but not in Marathi, sadly. But learning how to do things the way they're done or not. So when we conducted fieldwork here so many years ago, it was over a period of 7 months in one community, which was geographically bounded. But we did things like participate as you were talking to a group of women and they're washing their clothes by the river. I mean, it seems a bit ridiculous to start washing clothes as well, but doing something that puts you kind of on the same level helps a lot. Sifting, I mean, in Africa, in West Africa, people spend a long time separating the grains, you know, the stones from the grains before they get into the mill and all that. So you sit there and you sift the grains. And they'll laugh at you because you're doing it wrong, but actually that's an entry point, yeah? So trying to do things the way they're done or messing up is kind of part of that. So you become part of the social field, you engage, you transform the field as you do so, and you document it, yeah? So that's part of ethnography. Now you might say, okay, this sounds very cozy, very rosy, but actually practically speaking, it's not so easy. Because you have to maintain a balance, right, between being an insider. On the one hand, you're trying to fit in, you're trying to understand things from people's perspective. And I'm talking not just about the work in a community, as in a remote area where you're trying to understand people's health practice. I'm also talking about the person who steps into the lab situation or the operating theater. You can only be an insider to an extent. Because if you go fully insider, you're no longer a researcher. But vice versa, if you're fully an observer, it's very difficult to have that social connection. So does the observer, when are they participant and when is the participant an observer? And there's always going to be a tension between the two. There's no way getting around it. So as long as you document it carefully and you note moments of, you know, awkwardness, conflict, silence, all those things that can occur, that can shape the quality of your data, I think it's very, very important. So I always had breakthroughs in whatever fieldwork I was doing. When I mastered, for example, the accent, you know, like even working in an English-speaking country, but a country, so I worked in, my very first piece of fieldwork many years ago was in the Caribbean, and it was working with banana farmers and looking at, it was looking at practices to improve the viability of avoiding erosion of basically banana farming, easy but unfortunately not great for the soil. So they were mixing trees and bananas. Anyway, long story short point. But so they speak a very interesting English. It's a patois and it's very heavily inflected by West Indian, sort of intonation, sing-song, etc. And I remember being really proud when I was able to sort of speak slightly in that way, and it didn't feel fake. It felt, you know, it felt like I was just fitting in. So there are lots of moments that you have if you spend longer in the field. I also remember working in Tanzania and on an island which was very famous for black magic. And it's second nature. Initially you come and everybody's telling you, oh, no, you know, don't do this, don't do that, because there's devils here and there's this, and you kind of are just reeling. And then after 6 months, you just say, oh yeah, I'm not supposed to sit under that mango tree because it's possessed by a certain type of devils, and you know, I'll break out into a rash, so I just avoid that tree. And it just becomes second nature, right? So it just happens. You start, and it's not just about sort of strange cultural practices, it's also about other settings. So I think the trick is to start observing familiar settings as unfamiliar, yeah? So look for those beliefs, practices, norms, even in a setting where you don't traditionally associate. You don't think of as a lab as having beliefs, practices, norms. Or maybe the norms part, but you don't think of it as a place that is imbued with culture, but it is in a way, right? Anyway, so this tension between the participant observer is something that never goes away. Also the question about, are you known as a researcher? Because you might be saying to yourself, if you spend a longer period of time in a community and you're observing and your formal methods are now run out, so do you still continue? Just ask that question to you. What happens in those situations where you're spending a bit more time in the You think so? Okay. So how would you make sure that you do this in an ethical way? Okay, because your ethics protocol just takes account of your formal methods, yeah? Okay, so what strategy do you think you would use? Don't worry, we're going to get into this. We're going to do a whole session on this, but I'm just preparing you in advance, and I'm asking you about the situations where you're gathering information through informal contacts, informal observations, things that are not part of your official SOP. What do you do with that information? Anybody? Do you use it or do you not use it? Go ahead.
Ma'am, we can use it, and like before reporting it, we can priorly tell them that, you know, like this part of our interaction would be used, and take like not formal consent, but tell them that this will be used.
Okay. All right. So generally, I think you have to, whatever way you're going to use, because when you talk about doing field ethnographic field work, very often it is associated with a longer period in the field. It might not be 6 months, but it's definitely longer. So even if you go into a clinic and you say, I'm going to spend 3 days and do observations, you have to somehow convey to the staff and the people who are going to move through that clinic that there is going to be a researcher present in that clinic. So one way we did it is to organize 5 minutes during the staff meeting. And we would say, we're going to be here, we're going to do a series of formal things, which include interviews, observations, but we are also we're generally trying to understand how this clinic functions, okay? The other thing we could do is the work that we're doing in pharmacies at the moment in Belgium that I told you about, is we put posters in the pharmacies saying that currently you may notice 1 or 2 people who are not normally in this pharmacy. We are researchers, this is what we're doing. Yeah? So I think what's very important is you try your best to make people aware of the fact that there is a researcher, and you give them the chance, in case there is somebody who gets upset or wants to know more, you give them that you remain accessible to them. Okay? The other question is how much or what is known about the research. So sometimes you get in a situation where you are trying to do research about something that's sensitive. So let's say you were working in a field site, top level, and you're actually trying to understand conflicts across different kinds of, different political influences and how they're affecting the delayed implementation of a policy. You are not going to announce to them from the beginning that I'm looking into the conflicts, the delays, and the problems you're having there, right? You're going to have to stay neutral. But actually at heart, your research is about unpacking those conflicts that you know exist. So again, attention that you have to think about beforehand, yeah? And again, what are the limits of participation? So when we talk about participant observation, realistically, if you're doing research on whatever, alcohol consumption in young people, are you going to consume vast amounts of alcohol just to put yourself into that situation? Maybe, maybe not, okay? All right, so you need to be explicit about who you are in the field. And in qualitative research, but particularly for ethnographic research, it's important to be reflexive, which means you take notes, which include not just notes about what you see and what you observe related to your topic, but how you feel about what you see. So it's the day-to-day trivia. It's little things that you observe that might not be part of your formal observations, but it's things that strike you as interesting. It's your emotions. Okay, there are days where you're going to feel bored, you're going to feel, that things haven't been going very well, people are asking you what the point of this thing is. You're allowed to record that. You can record things that are surprising, where you make mistakes or you have doubts. And these are all reflections about how assumptions shape the research. Positionality is something different. So reflexivity is allowing you to reflect on things that are affecting the research and the course of research. And positionality is being very conscious about how your position as a medical doctor, as a scientist, as a woman, as somebody from a particular caste, is going to affect the interactions that you have. In a survey, nobody thinks about this stuff. They just assume it's a survey. Just go out there, do my survey. It is equally important because sometimes even conducting a survey is based on the initial rapport that the enumerator has with the participant. But you're being explicit about your position, your power, your hierarchy, your solidarity, or your control. So just like in a key informant interview, we think about our position, in ethnographic work, we're also thinking about our position. And we're thinking about the influence of our status on social relations in the field. Okay, so moving to what is it you're doing during ethnographic work. In contrast to data collection, where you're using some tools, formal tools, a lot of ethnographic work is just about taking field notes. And it's daily record of observations and experience. It's capturing things like terminology, quotes, some interesting quotes. It's capturing tensions you observe, your own position, your responses. And usually it goes through different levels, yeah? So it is difficult to take notes. It's not a very fun exercise. You'll see that because you're going to do an exercise soon. But basically, you are observing and you're making notes on what you're observing, which seems kind of boring, right? Because why, if you see it, why do it again in terms of notes? It's because you forget very quickly what you saw. And usually in the space, in the field, you don't have time to extensively write out a novel. So you're just doing quick notes, which are called raw notes. And then you're usually at the end of the day, or maybe after a few days, you're fleshing them out into more detailed descriptions. And you're already starting to make some notes in the margins, yeah? And this process from going from random notes to organizing notes to putting them under headings and eventually developing an ethnography. So on the right-hand side, you just see some very rough notes from an ethnography conducted in a surgical theater. And you can see that the person uses abbreviations, they're using some symbols, They're using some diagrams just to quickly capture what they saw, right? So what is it you take notes on? Often you're noting details of appearance, behavior, physical interactions. You're looking at what's going on during your visit. You might capture some of the conversation or the exchanges, and you might be taking notes on what you find unexpected or surprising. So the initial notes tend to be descriptive, okay, which means you're just describing what you see. So often there's description of the physical environment. Okay, this is just a small extract from field notes that was taken by a colleague, Professor Seeley, and this was in Uganda many, many years ago. So she's describing the interior of a small hut in a rural part of Uganda, and this was in context of a study on HIV and aging. Okay, so she's describing what she sees, right? The next step is kind of moving from the descriptive to the analytical, because as you take more and more notes, imagine you go back and you're visiting a number of households in the area and you're trying to manage how older people who have HIV are managing their duties as grandparents or whatever it is, and at the same time managing their medication, staying on long-term medication. So after you have conducted your preliminary field work, you've visited a few households, you've had a few informal chats, you're moving to a more analytical conception. You're getting a sense of what might be the coping strategies, what might be the household division of labor, what are older people doing, you know, what roles do they have, and how does illness affect their day-to-day experiences, their roles, etc. So you're moving to more interpretation. So your notes are becoming more analytical, and your notes are starting to generate some hypotheses or mini theories. So let's take this example. Yeah? We want to conduct field work in a support group for people living with some condition. Okay? This is somewhere in a European country, and there's a lot of peer support groups that are set up in rich countries for all kinds of conditions. So let's say this is a group of people that are living with something called chronic fatigue syndrome, which is a condition, right? Now, let's say you've been granted access, you've spoken to them, you have ethical permission, and you are going to do 6 weeks of field work. And that field work is going to entail interacting, taking part, but you're going to be sitting somewhere behind. You might be sitting, maybe there's a field worker hiding behind that tree. But essentially, you're going to position yourself in an unobtrusive way, and you're going to listen to what happens in these support groups. That's your main entry point. You might have individual interviews with different people later who are affected by the condition, or with people who are part of their families. But one piece of work is just attending these support group meetings twice a week. Okay? So in the beginning, you don't know much about what goes on. So what is it you're going to be doing? What do you think you're going to be taking descriptive notes on? What are you going to notice?
The setting of how each and everyone is sitting, and who is facilitating that support group. So generally there's one person who facilitates the discussion. So maybe something around that, and
Okay,
descriptions around that.
Good. But even before that, purely descriptive, what are you going to be describing?
The number of people in the support.
Exactly. The number of people. What else about the people?
Their age.
Yeah. Gender, how many men, how many women, age, physical characteristics, right? And go ahead.
Yeah, how they are sitting, like the sitting arrangements, what they are wearing, how they are behaving, their expressions.
Yeah, exactly. Okay. So the first round of meetings, you're probably still focused on looking at physical characteristics, how is the meeting organized, structure. Gayatri, you started to talk about, so structure is already moving towards analytical, yeah? Okay, now you've attended 4 meetings. What do you think you're going to move towards now? Now you're going to become more analytical.
We can see that who are interacting, who's not interacting, who's speaking less, who's not speaking, and what are the conflicts between two people, who's opposing the ideas, and all this.
Yeah, absolutely. Okay, so you're going to start to understand more about the dynamics of this group, yeah, and you might start to see, you might start to characterize the way people contribute to the group, their tone, their content, their agendas, their motivations, right? And then a third set of notes further down the line, let's say you've had the chance to attend 8 meetings, might be actually how do these, ultimately it is related to your question, which is how do the peer support groups make a difference for people's health and well-being? Because even through observing this group, you're going to notice things about people's level of satisfaction, their contentment, their willingness to speak, and in conjunction with the observations, you will also hear about how they're doing, because they're going to share a lot about their lives. All right, so you can see how spending 6 to 8 weeks in this group will allow you to progressively develop something more theoretical about what is the relevance of peer support groups for people with chronic fatigue syndrome in terms of their health and well-being. And what might be very interesting is that you notice that it's very different for men and women. Or maybe there's people of different nationality, and it seems to be more, like I explained to you in Canada, the difference between what I found for English-speaking versus French-speaking people living with HIV. So, anybody have a clue as to what this is called, moving from purely descriptive through to setting, giving meaning to what I'm seeing and hearing? What is it called in anthropological terms? Okay, it's referred to as thick description. Okay, a thin description is he is wearing a white shirt, blue pants, roughly 55 years old, graying hair. That's a thin description. Thick description is you start to interpret. Because you've been there for a while, this person assumes a prominent leadership role. He does so by asserting himself physically, the way he sits, the way he spreads his body, yeah? You're moving to a thick description by virtue of understanding more and more about the context in order to give meaning to what they say and what they're doing. Okay? So now we go back to the pharmacist. So here is our thin description. The elderly man enters the crowded chemist shop. He asks the pharmacist's assistant on duty for a particular medicine. The assistant hesitates and calls to the back of the shop. And the pharmacist comes to greet the man, nods to the assistant, who goes off, gets the 2 strips of tablets, and hands it to the customer. Okay. A thick description, which means you have been in this pharmacy for a while, and you've observed not only different interactions between older people, younger people, people of different backgrounds, but you've also noticed that this man comes in fairly regularly, this elderly man. So the thicker description could start to look at how is this pharmacy organized spatially, and what does it mean with respect to the division of labor, okay? How is it organized in terms of material? Is it well organized in contrast to the pharmacy that we saw before on the earlier image, which looked quite chaotic because it was just absolutely stuffed? So what is the organization? And what is the organization of the medicines, the type of medicines, where they're stocked, how people access them? What does it say about the pharmacy itself? We might start looking at procedures and routines. So what is the standard, what happens when somebody enters, who attends to them, and how? We might look at the timing of events. So if 3 people come in at the same time, is any preference given to one person? Do some people take longer? Is more advice given to one person than the other? And we might look at the division of labor. So 2 pharmacists on duty, one is more junior. What's the division of labor there? And we might understand the communication or interaction with the clients based on gender, age, and other verbal and non-verbal indicators. So let's say this person has a very high standing, so high caste, very revered, but also very stern, and commands authority just by the way he comes in, demands the medicine. They don't even bother with the prescription. I mean, I know that's the case anyway for many pharmacies, that you don't really have to ask for a prescription. I mean, you don't have to show a prescription. But there may be quite a lot of not so subtle differences in the way this man is treated than the next person who comes in, who is, in terms of the social status, further down the ranks. So there's obvious markers and symbols of knowledge and skills. Again, the issue of tacit knowledge. Yeah? And the nature of the exchange and transaction. So this is a description of how you can move from thin description, purely describing what you see, to interpretation, which is a thicker description. Okay, we're going to end with some examples of the ways in which ethnography, which always involves some kind of thick description because you have the luxury and you have the time to set things in their context. So we're going to look at ethnography in health research. One example is so-called single-sited ethnographies, where you stay in one site, and there are many different examples of single-sited ethnographies. So one is following, for example, the life or the lives of individuals that are affected by a particular condition. How are they enabled or hindered in their efforts to manage conditions and make use of available services? So a nice example, back in the 90s, there was I think he's still there, a very well-known anthropologist called Vin Kim Nguyen. And he wrote a book about how people living with HIV drew strength from solidarity, from associating themselves with other people with HIV, and forming coalitions, forming groups that became very pertinent in terms of demanding access to treatment, or also just supporting each other in terms of care and solidarity. So movements that were particularly important came up, of course, in the United States, but also in parts of Southern Africa, and he called it therapeutic citizenship. So this idea that people formed a homogeneous group, they became a community that was tied to each other by virtue of sharing this identity in terms of needing access to treatment. Okay? Another example of a single-sited ethnography is the focus on providers and professional socialization. So this is understanding how a particular set of health providers, for example, mid-level managers, for example, CHOs or ASHAs, how are their roles, practices, and working relationships formed? How do they influence the ways in which healthcare is delivered? So there's been a lot of work on nurse-clinician relationships, for example, the acculturation of medical students, or the role of particular lay health workers. So professional socialization means the pathway through which you become a health worker. Okay? So this is the nice ethnography that I mentioned to you before. It's called Special Treatment, Student Doctors at the All India Institute of Medical Sciences. And it is a very solid ethnography of a particular institution that has a very high ranking in the country, that has cultivated a status around studying medicine. And here's the quote from the back of the book. Ruddock untangles the threads of intellectual exceptionalism, social and power stratification, and health inequality that are woven into the healthcare taught and provided at AIMS, asking what is lost when medicine is used not as a social equalizer, but as a means to cultivate and maintain prestige. Okay, now we can argue with her perspective, but she did ethnography for quite some time, interviewing people at different stages, but also interviewing people who never got into AIMS, and understanding the power dynamics around what it meant to get in and to stay in the institution. It's a really, really interesting, I examined her thesis and I was really impressed because it was, I think you've met her, haven't you, Solomon? You know her, yeah. Okay, so another third aspect of a single-sited ethnography is a focus, we've talked about focus on patients, focus on providers, but also focus on organizations. So you may have heard of the expression institutional ethnography, and this is where you're looking at the institutional as a whole. So this is your kind of meso-level ethnography. How do work activities shape and maintain the institution? How are they connected to other social processes? And this is an example of a hospital ethnography. It's called Wandering the Wards, an ethnography of hospital care and its consequences for people living with dementia. So they're looking at how being institutionalized for a condition impacts on your pathways and your simply your experience of living with the condition. Now, I noticed that this is not only a book, but this has become a podcast. So I'm going to try to find the link for you. It might be very interesting. I'm going to listen into it myself. I think it might be interesting. Okay, now we talked about single-sited ethnography. Now we're going to talk about multi-sited ethnography. So multi-sited is exactly what it sounds like. It means you move around, okay? Because your study, by definition, if I'm looking at PPM, I might have multiple sites. I might want to understand its origins at the international WHO, international organizations. I might want to understand what's happening at the national level, and I might want to go right to the frontline interface, yeah? So it means you follow a topic through different field sites, geographically or socially. So a typical, another example would be if I'm working, for example, I mentioned a project that we've just put in a proposal for about mobile populations. So our ethnography has to be a mobile ethnography because we want to understand how men who stay away from home for occupational reasons, for their livelihood strategies, how they're drawing on different assets at different points. And so that's going to mean going with them and understanding at each point along their trading or trucking route what life is like for them. Yeah? You can explore the movement of commodities. So some people, there's an interesting work that was done in the 90s on the social lives of medicines, where they actually tracked medicines from their production in India to their distribution in Uganda. And along the way, they conducted ethnographies with different actors to understand how the meaning and the value of those antiretroviral drugs was transformed at each step. So that the Indian produced, Cipla produced antiretrovirals, you know, how were they ranked in relation to ones produced by other companies, etc., by the time they got down to the field level. You can also track transnational processes. So this is if by definition your topic means that you need to move around the world or within a country. You might be tracking people who are inherently mobile, or you might be tracking the genesis of an idea. So very often in health policy and systems work, we might be interested in policy transfer, how a policy that was developed in one place is implemented in a number of countries. And it requires really a macro level perspective and understanding of globalization processes. So this is not so much a micro level thing, but the original concept for the ethnography might be a macro level one. Okay, we're going to end. Now you might be saying, look, thank you very much, but I'm not going to do this ethnography business. It sounds too complicated, too long, too much interpretation. I would still say that you can still employ some of the thinking in your work. Essentially, to be a rigorous ethnographer, you do need to conduct field work. You do need some aspect of participant observation. You think about your methods as being more open-ended, more flexible. You triangulate methods. You definitely use thick description, and you have some, a degree of reflection, reflexivity, but positionality. So I still think whatever research you're doing, you can do a number of things. You can ensure that rapport building through learning language, understanding how people do things the way they are doing them, entering into their shoes, okay? So with many of your topic guides, I was saying to you, flip it around. Try that topic guide out on yourself. If you can't understand it, nobody's going to understand it, all right? So always put yourself in those shoes, yeah? The other thing you can do is you can definitely work with more in-depth and flexible methods. You'll be surprised how rich some of that data can be. Even if you can only do 1 day of observation in a health center, or you can accompany one Asha in her work, or you can see a day in the life of somebody, it's going to be so rich than rather not doing it at all. And any kind of analysis, bear this in mind, that you're moving through levels of interpretation. If you have a relatively short time, you might not be able to do that really thick description, but you're going to be still offering something about interpreting a situation in context. So all of you, when you looked at the transcript from the South African clinic, were at different levels of description, analysis. And I think one table was quite strong in terms of already moving forward in terms of analytical categories. Okay? The disadvantage is they were only looking at one transcript, so maybe they were over hasty with those categorizations. All right? Okay. So don't worry about this homework. This is related to a paper which is a very interesting paper on maternal wards in Bihar. But I think we're going to see how you get on this afternoon. We've got another session on observation, and we're actually going to ask you to conduct an observation, so that may be plenty. I will put this paper up for you on the Moodle, or Sakshi will do that, and it can be an optional task that you do if you want to do more reading, okay? Because some people complain, you didn't give us enough papers, we didn't do enough reading, so I want to make sure that's not the case, okay? So we'll stop there.